Oops, I'll go back.
There you go. To go back, to go up, to go forward, to go down.
Hello, everyone. Thanks for letting me speak today. I know pretty much everybody, and I think everybody knows me. We'll just get started. I've been given the simple subject of fluids and electrolytes, which you can probably spend 3 months talking about. I mean, there's so much that, in the literature and debates, and a lot of this will probably go back to your nursing education of all the things you tried to forget, and we'll review them right now. If I can figure out how to use the pointer.
The red dot.
Down. Down button.
Okay. Most of my talk will be geared a little bit to the surgical patient. That's what I'm used to. And basically, you have to know your fluids and electrolytes to manage the surgical patient. The ionic composition of the blood is affected by so many things with patient's injury, infection, inflammation, drugs, and the IV fluids you give. Just a simple example at the bottom, you can lose 1 to 1.2 liters a day just for insensible loss. You can lose GI loss if you have any diarrhea, and up to 250 cc's a day, and even a fever. If every degree above 99 increases your losses by 10%. And it's so important to keep track of that. That's why I&Os are so important. And I know it's a tedious job, but it's probably one of the most important things we do for a patient. The bare minimum of urine output for a person has to be 400 cc's in 24 hours. And that's just to get rid of whatever waste product, solute load that your body's trying to get rid of. The bare minimum is 400 cc's. It's affected by the antidiuretic hormone, which is released under a number of conditions by the hypothalamus. And that also is dependent on your serum osmolality. And if you remember the formula, it's at the bottom. It's also calculated in your CMP blood work where it says calculated osm, and that'll tell you the concentration or the tonicity of your blood in your patient. An example, and now we're dealing with the water composition of the body. Typical healthy male, 70 kilograms, fairly lean, unlike most of our patients. Muscle and solid organ. Our obese patients have more fat. They'll have a higher water content. The total body water of a typical male is 45 liters. 2/3 of that is intracellular. 1/3 is extracellular. And we break the extracellular down to 1/4 of the extracellular is intravascular in the blood, 10% of the total body water, and 3/4 is the interstitial fluid, which is primarily the two areas that we deal with when we're taking care of a patient. We don't really talk about the intracellular fluid too much. That's just, numbers are a little different, but you get the idea. Most of the water is intracellular, and less is extracellular, and then the plasma volume is, it says 5%, there's 10%. And then the interstitium, which comes into play as we go into the next few slides. For instance, if you're dealing with potassium, the principal cation in the body, it's an intracellular ion. It's not predominantly in the blood, it's in the cells, which comes into play when how you measure it and how you correct it. Sodium is extracellular, magnesium is intracellular, calcium is extracellular. And chloride is your principal anion, goes along usually with sodium in the extracellular. And then you throw in the protein, which produces your osmotic balance or osmolar balance of fluids that dictates flow of fluids between the plasma and the interstitium, or across the capillary membrane or the endothelial membrane of the blood vessel. Very important structure. They used to think it was pretty, they didn't think it was very important, but it's very active physiologically. And wherever the sodium is usually where the water is, extracellular fluid. And so depending on what type of IV fluids you give will determine how it's distributed into the extracellular compartment. And again, either intravascular or in the interstitium. This is an example of your distribution of your electrolytes in the interstitium or the intracellular fluid. And again, sodium and chloride are predominantly in the interstitium and the plasma, and potassium is intracellular along with phosphate and magnesium. Sodium conservation dependent on a lot of factors, which we won't get into, the renin-angiotensin axis, aldosterone, adrenal cortex. Anytime we try to conserve sodium, we will conserve water. And again, it's affected by all these issues we see in patients: pain, hypothermia, injury, infection, hypovolemia, and a degree of acidosis. Potassium, again, intracellular, regulated extracellular by the kidney function. But if you measure potassium, it's a poor indicator for how much potassium you have in the body. Basically, you measure potassium, it's 3.5. You're probably a lot lower than you really expect. If you're measuring it's 2.9, you're going to get into trouble, because your plasma compensates its potassium by drawing it out of the cells. So as you get low, it takes it out of the cells, and if it's very low in the plasma, that means you're actually probably running out of intracellular potassium, and your patient needs to be replenished, or we won't get into trouble. Calcium, regulated by GI loss, renal excretion, but primarily in the bone and the extracellular fluid, which is affected by vitamin D and parathyroid hormone. 98% of it's in the bone. Now, when you measure calcium extracellularly in your blood, most of it's protein bound, i.e. with albumin. A small portion is ionized, and then the remainder is complexed with anions such as bicarb and citrate, which we don't really measure. So when we look at just a basic calcium, I mean, the patient's hypocalcemic, and most of you know this, if the serum albumin is low, you add, for every drop of 1 gram of albumin, you add 0.8 milligrams to your calcium to correct for that, unless you're going to get an ionized calcium level, which is pretty good here because we get them right away and it's easier to follow. I think it helps particularly post-thyroidectomy, total thyroidectomies, and parathyroidectomies. Magnesium intracellular, muscle and bone, phosphorus, 80% bone, 19% intracellular, and only 1% extracellular. And as an example, with IV fluids, our basic need, 30 to 35 cc's per kilo of fluid, 1.8 milligrams per kilo of sodium, 1 milligram per kilo of potassium. Figure that out, the numbers are there, and you run it at 1.25 to 1.5 cc's per kilo per hour, and that's basically 1/3 normal saline. So what do? We give half normal. The books say that the body compensates for short-term IV fluids. You don't have to be exact, but and I've been away from pediatrics a long time, would probably be different in peds, but in adults, we end up giving half normal for maintenance, like D5 half normal with 20 a K, and the body will adjust. In case you want to review this slide, it lists all your different solutions, their contents. What I found interesting was, if you look at normal saline, you're given a fairly acidotic solution. 5.7 is the pH. Lactated Ringer's is a little better, 6.7. Those are two of the most popular, D5 half normal and D5 LR. And these are your hypertonic solutions, which we'll talk a little bit about. And this acidity actually comes into play in treating some disease processes. Volume deficit, how do you lose fluids, particularly in a surgical patient? And this is extracellular fluid loss, either by losing blood, intestinal loss, as in a bowel obstruction or a fistula, sequestration of fluids, where the body just hangs on to the fluids because of injury, infection, peritonitis. Whatever you lose, it's similar to the concentration of the blood. You can restore it with, restored with either normal saline or LR. And these are assumed to be isotonic fluids. They're given into the intravascular space, or at least you think you're giving them into the blood, but they are distributed into the interstitium and the plasma volume by usually a 3-to-1 ratio, and I'll show you in the next slide. So when you see the Michelin Man and Dimatis patient, you think he's in positive fluid balance. It doesn't always. That may indicate an expanded extracellular space, but not necessarily your intravascular space. And that's why you can have a patient swollen like that and still be hypotensive. You give normal saline, it expands by increasing your sodium and your chloride. Because of its acidosis, its chloride, you can get hyperchloremic metabolic acidosis, which we see sometimes in their patients. And hence surgeons choose LR for their surgery and for their trauma patients, which is sometimes different than the medical patient. So if you give a liter of this fluid, D5W, here's the 3-to-1 ratio you always hear about of normal saline. 1/4 will stay in the plasma volume, and 3/4 will go into the interstitium. If you give albumin, it's almost half and half. If you give hypertonic saline, it's almost half and half, maybe a little bit towards the interstitium. And that's why there's so much debate on which fluid to give and when, and that debate's been going on for 50 years. How else can you lose fluids? GI is very common. Our patients are vomiting all the time. You lose hydrogen, you lose chloride, and you lose potassium. So you become hypernatremic, hypochloremic, metabolic alkalosis. And why do you lose, why are you hypokalemic? You don't vomit it, it's a reaction by our body to try to preserve hydrogen. You're losing hydrogen, the body wants to save hydrogen and correct its acidotic state or its alkalotic state. So the kidneys start preserving hydrogen at the expense of potassium and gets rid of potassium. And that's why these patients are hypokalemic as well. Small bowel obstruction, you can third space liters of fluid into the bowel if it doesn't get repaired. And diarrhea. Opposite, you still lose sodium and potassium, but bicarb this time, and you become hyperchloremic metabolic acidosis. And that's one of your many non-anion gap metabolic acidoses that you read about. Here is an example, a chart on what you lose every time you lose a certain amount of fluid: saliva, stomach, pancreas, biliary tree. Fair amount of sodium chloride in the pancreas and biliary tree. That's why small bowel fistulas are, important, losing a fair amount of volume and electrolytes for the ostomies and then the gastric. All that's in your handout. So similar chart and the type of fluids that are often given to replace either normal saline lactated ringers. You'll see me order a lot of times half normal with 20 K to replace the stomach contents or even the diarrhea contents, half cc per cc per shift, for the previous shift coverage. And that just helps you keep up with some of your losses. Let's get into the specific problems that you'll see. Now, some of this may be review for some of you, and some may be just a refresher. Hyponatremia, less than 134, common in surgical patients due to ADH release, secondary to stress. You see it often in diabetics, and basically it's a pseudo-hyponatremia because of the translocation of cellular water that moves from the cell to the extracellular fluid because of the glucose that's in the blood. And glucose is an impermeable solute, so it increases the colloid oncotic pressure and the water shifts. And then that dilutes your sodium and it makes you think you're hyponatremic, you really aren't. So for every increase of 100 grams of glucose, you drop your sodium by 1.6 milliequivalents. And treatment would be water restriction. If it's acute and you're symptomatic, you give hypertonic saline. You have to be careful how quickly you replace it. 2 milliliquids per liter per hour. No more than half the sodium deficit in the first 24 hours. You correct it too quickly, there's movement of the fluid, and you can get cerebral edema and seizures and get the patient into trouble. Hypernatremia greater than 144, usually from loss of free water. GI, your vomiting, fistula, open wounds will weep a lot of fluid. Osmotic diuresis. I mean, this is probably maybe more common than people realize. Our patients, and this is why the glucose protocol is so important. Our patients are spilling glucose in their urine, and I just told you there's only a certain amount of volume the urine has to put out to get rid of that solute load. And if your sugar's 500, 600, 700, and you're pouring all this sugar in the urine, the body's going to put water into that urine and lose it, and you can become lose water enough to become hypernatremic, and it's just an osmotic diuresis from all the sugar. So you can have nephrogenic or diabetic insipidus, other metabolic causes of loss of free water. Symptoms of restlessness, confusion, lethargy. Obviously, treatment is to replace the free water again in increments. You replace half of it in the first 24 hours. You can calculate the deficit by that equation, 0.6 times weight times sodium divided by 140 minus 1. Maybe by the end of the talk I'll figure out this pointer. Okay, let's see, hypokalemia. Inadequate intake, GI loss, again, urinary loss, and diuretics. I mean, I can't begin to tell you how many patients I see in the office that are given Lasix and various diuretics and aren't given potassium. Their sodiums are 2.8, 2.9, 3.2. And potassium is important because it actually changes your electrical membrane potential, and you get muscle weakness, you get ileus, doesn't want to work. Profound hypokalemia, you lose your reflexes, your deep tendon reflexes, and then cardiac. ST segments are depressed, T waves are depressed. You prolong your QT, and you get arrhythmias and you die. You have to treat it. I always check a magnesium, those of you who know me, because that's one of the #1 causes of hypokalemia. If you don't correct the hypomagnesemia, you will not correct your hypokalemia. Hyperkalemia, you see a lot in our unit, greater than 4.9. Usual causes, renal failure, but tissue loss in the surgical patient, ischemia of a leg or a gut. Anesthesia sees it if they accidentally give succinylcholine to a para or quadriplegic, because the muscles are dormant for so long, the potassium gets released. Symptoms are nausea, vomiting, and primarily, as most of you know, cardiac peak T waves, wide QRS, and then cardiac arrest. Treatment, 10% calcium gluconate, insulin glucose, infusion, 10 units of insulin, 50 grams of glucose, K-Xlate if you have time, and dialysis emergently in some patients. Hypocalcemia, less than 8. Surgically, the most common cause is parathyroidectomy. Or a thyroidectomy where they injure the parathyroids. Total thyroids, particularly, these patients need to be watched. The blood supply to the parathyroid is so tenuous. It's one tiny little blood vessel, and if you move that parathyroid, or you hit it, or you push it out of the way, you hurt the blood supply, and the gland dies. There's 4 of them. If you suspect that you took one out by accident or you hurt one, you can take it and chop it up in little pieces and transplant it into the arm muscle or the sternocleidomastoid muscle, and the body will eventually revascularize it and save that gland. Other causes of hypocalcemia in the pancreatitic, basically it's saponification of the tissues that are injured. It's basically soap. Calcium binds with these tissues, and you drop your calcium. We'll talk about that in later slides. Small bowel fistula, paresthesias are the symptoms. Neuromuscular irritability again. Most nurses know these signs, particularly Those of us with gray hair, Shove-Stack sign, a Trousseau sign, tapping of the jaw causes spasm and twitching of the mouth, blood pressure, holding it at you have to look it up sometimes, I think between 100 and 120 millimeters, and look for spasm in the forearm, movement of the hand. Prolonged QT, and then ultimately VFib if it's not corrected. Treatment, I use calcium gluconate. Some people will use calcium chloride, although it appears to be more toxic. Chronic treatment is calcium and vitamin D. Hypercalcemia, greater than 10.6. Not terribly symptomatic until you're over 13. We see it in hyperparathyroidism. Prior to measuring calcium in the blood, these patients actually had to become symptomatic before we realized they had a parathyroid tumor years ago. But now we just do a lab test and we see that the calcium's high and the parathyroid's high. But once you get over 13, lethargy, coma, nausea, vomiting, those causes are usually, at least the times I see it, are due to malignancy, metastatic breast cancer or various cancers. Treatment, IV fluids, diuretics, calcitonin, and the biphosphonates that can, for chronic treatment, to bind the calcium. Hypo and hypermagnesemia. Hypo is less than 1.8. It's probably more common than we know. GI and renal loss, neuromuscular irritability, cardiac issues, and hypokalemia, as we spoke about earlier. Treatment is replacement. Greater than 2.3 is hyper. Very rare renal insufficiency. Symptoms usually have to get up around 5 milliequivalents per deciliter. Hypotension, nausea, cardiac arrest. Treatment is counteracted with calcium, diuresis, and usually dialysis. Hypo and hyperphosphatemia. Phosphate less than 2.5. Muscle weakness. Interesting because it interferes with your production of ATP, which you need for muscle function. So these patients can actually go into respiratory failure if it's unrecognized. Replace it with sodium or potassium phosphate, and again, they give you a measurement of between 0.08 to 0.24 millimoles per kilo within 6 hours. Greater than 5 phosphate, renal failure. And again, malignancy, tumor lysis syndrome. They give this aggressive chemo. As surgeons, I don't see it too often, but maybe you do in the unit. For leukemia or lymphoma, the breakdown of the cells is so profound that they release phosphate. So it has to be watched for. Chronically and maybe even acutely, it'll bind with calcium and cause metastatic calcification. These patients will have hard areas all over the body with calcium phosphate. And treatment is with phosphate binders and dialysis. We'll shift a little bit and get into fluids and shock. I'm going too fast or okay? Shock has a lot of literature on it, and you hear about it a lot in your ACLS and ATLS. It can be decompensated because of poor cardiac function or compensated adequate cardiac perfusion. The types are listed: extracardiac or compressive shock. And you'll see more in the next slide, such as tension pneumothorax, cardiac tamponade. Basically something around the heart that's keeping it from functioning. Hypovolemic shock, which we'll talk about mostly here. Neurogenic shock, spinal cord injury patient, paralysis. Cardiogenic shock, which you probably see a lot of with an acute MI. Our favorite, inflammatory shock, which is basically sepsis, also called distributive shock. And that is at the cellular level, at the endothelial level, the membrane I spoke about along the blood vessel and the cell membrane. It's disrupted metabolically. It also dilates the vasculature and gives out the myocardial depressant factors and depresses the heart in this type of shock. So compressive, tamponade, pulmonary embolism, tension pneumothorax, hypovolemic, bleeding, blood and fluid loss, as we talked about, inflammatory, complex response, various causes. Neurogenic, because the blood vessels underneath the cord injury just don't work. The blood just pulls in your legs and your trunk, and you go into shock. There's no tone to the arteries to allow them to compensate. And then cardiogenic MI arrhythmias. For those of us that still look at the patient, these are the symptoms: hypotension, tachycardia, or bradycardia, tachypnea, hypoperfusion of the skin. Thus, it's septic shock. The skin is warm. Vital status changes: oliguria, metabolic acidosis, myocardial ischemia, and hypoxemia. And treatment, again, depending on the types of shock, but with hypovolemic, either lactated ringers or normal saline. Just clinical features we talked about. For instance, cardiac output decreased, hypovolemic, but inflammatory, it can be increased, high output cardiac failure. Neurogenic, the heart tries to compensate. Oxygen consumptions decrease in all your shocks. Temperature decrease in hypovolemic, but can be increased or variable in septic shock. And then the skin is, as I said, sometimes can be pink, warm in septic shock as opposed to pale in the pool. So interesting, different types of shocks, how they present. Hypovolemic shock, talking about the endothelium again, it's important in the regulation of the microcirculation. The blood flow, it's not a passive organ. I mean, it's very active. It produces prostaglandins, endothelins, angiotensin II, all in response to shock. So our goal is to protect it, to give adequate fluid volumes. ADH, again, comes into play. These patients get back to your basic Starling forces, cardiac compensation for the low blood pressure. As the shock progresses, you can lose membrane integrity, you can lose intravascular oncotic pressure, and have fluid shifts in the water, which we'll talk about in a minute here. Trauma, fourth leading cause of death in the United States. The crystalloid-colloid debate has been going on. You know, I was a resident 30 years ago. They were talking about it then, so it's been going on at least 50 years. And most of you know how I feel. I'm kind of a crystalloid kind of guy. I don't use a lot of colloids, unless it's blood, but it's still. And again, it depends on the type of shock, as I'll show you. A lot of interesting things have come out in the last 10 years. They were talking about how aggressive to be with fluid administration in the field. You know, why would you resuscitate a patient while his bleeding diathesis persists? I mean, he's still bleeding. Why give him fluid? It's just going to keep bleeding out. So they tried, you know, what's called a permissive hypotension. They just give just enough to maintain the blood pressure, but not enough to keep him bleeding as much. And I'm not sure they still do it or not. Maybe Carol or Tara knows, but it came out of Texas with Basil Pruitt. He's the head trauma guy in the country. And a lot of this comes from the Army too, you know, because they're resuscitating these patients out in the middle of nowhere, and you've got to get them back to Germany. They've divided resuscitation into 3 phases: from injury to operation, phase 2, intra-op, and immediately post-op. And you guys get your own phase 3, for the ICU resuscitation. When I went through, and I don't know that they correlate directly, under Lucas and Ledgerwood in Detroit, they did a lot of work with shock. It was called the resuscitative phase, the sequestration phase, and the diuretic phase. And this was from the injury to the end of the operation. We gave fluids to resuscitate the patient. This is from the end of the operation to usually about 36 hours or so. And the body will take on fluid. And this is when you can tell patients, I mean, you've heard me say this in the unit, this is how you tell patients are getting better. They start getting rid of their fluids. And this is kind of a biased population because most of your trauma patients were young, you know, and it's hard to correlate a lot of this in the older patient. You later realize we can't give a 80-year-old, 35 liters of fluid. I mean, you have to be careful. The initial treatment, everybody knows, 20 cc's per kilo over 5 minutes, up to 15 minutes. You can repeat it 1 or 2 times. If you're not making any progress, you better do something or go to the OR. Some people like normal saline, but again, you can get into hyperchloremic metabolic acidosis. And you got to understand, most of these patients are already acidotic and hypotensive from the trauma, so why give them something that's going to make them more acidotic? Lactated ringers, I hadn't heard that term in a long time when I was reading for this talk, with acetated ringers. The lactate to acetate binds with the protons, makes an organic acid, goes through the liver, gets processed through the CO2 and water, and the CO2 gets excreted, provided the patient's breathing. And that's how lactated ringers keeps down the level of acidosis and actually helps buffer the shock. So needless to say, it's the solution of choice for surgeons. No glucose, because most of their blood sugars are already high from the release of epinephrine and cortisol. Hypertonic saline has come into debate, using that even with initial resuscitation. I don't think it panned out. Albumin, not recommended in the initial presentation, at least in trauma patients, and there is even some literature that suggests it probably decreases survival. Now that goes a little different in sepsis, which we'll talk about. And in the usual monitoring CVPs, we do a lot of. We haven't done a SWAN in a long time. I don't know if they'll come back or not. I get a feeling they may start coming back. Inotropic support and vasoconstrictors, particularly that's the treatment of choice for neurogenic shock. Crystalloids, when you give them, remember it's a 3-to-1 ratio. You give a liter, it flows across that membrane, and 1/4 stays in the blood and 3/4 in the interstitium. Colloids are different. These are your different colloids. Albumin, which is the more common one, naturally occurring plasma protein. Its weight is 69 Daltons, molecular weight. Dextran, 2 types. It's a glucose polymer, 6% dextran, 70 Daltons. 10% dextran, 40 Daltons. And these will increase volume better than crystalloid initially. So you get a 600 to 800 cc increase for every liter of dextran 70, but they have their side effects, all these colloids. Coagulation abnormalities, binding to the platelets, bleeding, oozing, and allergies, where the gelatin is the next one, which I've never used. They're off the market since 1978 because of the high allergy risk, modified beef collagen. Hetastarches, you've heard of, hydroxyethyl starch, polymeric glucoses, hetastarch, pentastarch, and they come in various weights, low, medium, and high. Again, coagulation effect, and that's dependent on how heavy the colloid is. And the hypertonic saline, 3% to 7.5%. This is a breakdown of what they contain. Just take a look at it. Sodiums and or albumins and hetaspan. Actually, the sodium is isotonic. Both of them are isotonic, which is interesting. And you get into the measurement of colloid oncotic pressure, again, dependence on the fluid, amount of fluid in the system, how much protein. Crystalloid obviously will decrease your COP just because the dilution effect of water. Albumin, and this is why people use it, is thought to increase it. I don't know how many times you hear the doctors say, well, give some albumin and then a little Lasix. The albumin will draw the fluid in, and then the Lasix, given at the appropriate time, will help diuresis. And again, it depends on the integrity of your endothelial membrane. If the patient's sick from trauma or sepsis and that membrane's leaking, that albumin may just leak right into the interstitium, just like the crystalloid. So, but the studies with inflammatory shock or sepsis probably suggest a slight improvement with albumin, and even hetastarch would help stabilize the membrane. Some of the other in-organ effects of colloids, renal effects, they talk about the excretion. of the colloid. You get hyperviscous urine, obstructed renal tubular. So in some studies, there's a slight increase in renal failure in these patients. So there's never a free lunch in medicine, no matter what you do. You give something, you can measure it right here. But if you don't measure it down here, you don't know what you're doing. That's like, when PEEP came along, oh yeah, PEEP's great, increases your oxygen, but they never measured the basic oxygen levels at the cellular level, and they realized sometimes that maybe too much PEEP was not good. Here's your ATLS. I guess Carol went over that. The 3-to-1 rule. No indications for colloids initially. 4 phases of hemorrhage, in case you forgot from 2 hours ago. Mild, moderate, and severe, and the controversy continues. I always like this little chart because it shows the difference between a baby and an adult in terms of shock. These little babies can go up to 160 a minute, and then you start saying, well, maybe the babies have a problem. Same thing, skin color, mental status changes, urine output. Adults, we like at least a half cc per kilo per hour, although most of us go for 1 cc per kilo per hour. Acidosis, and then hypoxia. This is a good journal, this American Thoracic Society journal. I mean, they're always coming out with comprehensive statements on everything. I kind of reviewed this one for today in American Journal of Respiratory Critical Care Medicine. Crystalloid versus colloid. Colloid increases your colloid oncotic pressure. It's synthetic or non-synthetic if you use albumin, and it's expensive, which in today's day and age becomes an issue. Side effects, does it stabilize the membrane? Some people believe it does with sepsis. It affects your white cells. It causes adhesion of your neutrophils. It may impair activation. It affects your coagulation and the in-organ effects, as I stated, on the kidneys. I think it's right here. Increased risk of acute renal failure of 2.6 with head of starch and sepsis, and some CNS effects on circulation. The expansion ratio of colloids with sepsis is 1/4 to 1/2 volume, as opposed to the 1-to-3 ratio. And so maybe there's a slight benefit with isooncotic albumin. With respect to perioperative shock, we did what's called the SAFE trial. I think it was like 7,000 patients. And ultimately, the bottom line, they did slightly favor crystalloid over colloid. But that's a different type of shock, different type of patient. And they thought there was an overall increase of mortality of 1.36 with colloids. And leaving that, we're going to go to a different type of shock. I was asked to maybe address a couple of disease processes, and one of them was acute pancreatitis. And I just as an anecdotal observer of the care of our pancreatitis patients, I just question, how well some of them have done, and could we have done more to help these patients? And some of it, I think, gets to a fundamental knowledge of pancreatitis and how it should be handled. And it's even reached the higher committee levels. Dr. Kajani just gave a little talk on it as well, because some of these patients, you have to be a little more aggressive. And probably should be directing that more to the doctors than the nurses, because they're the ones that are directing the orders. More aggressive, with their fluid management and intense monitoring. I'm almost to the point I think every pancreatic should be in the ICU, just so they can be watched and taken care of. But it's a very bad disease when it wants to be bad. Luckily, most of them are mild and patients will get better. But it's a disease where you have to let it take its course. There's not a whole lot you can do except support the patient. That's where the nurses are so important. Mild, moderate, severe, various causes I'll get into. Severity depends on how it looks, particularly on CAT scan, pancreatic, surrounding peripancreatic fluid, cyst, necrosis, or what we used to call phlegmon. Whether or not it's infected comes into play with your decision on whether to operate, which most of the time you try not to operate. And we get into how do you grade pancreatitis. You know, I grew up with Ranson's criteria, very good criteria, still works. Apache 2, very complicated. I don't use it because I can't remember it unless I pull it up off the computer. And then there's a new bedside one called BISAB, which is probably going to become more common. When they come in, you image them. Most people, literature will say get an ultrasound, hold off on the CAT scan unless it's indicated. I think, unfortunately, in our ER, I think they have a CAT scanner in the door, so as you walk through, like in an airport, they get scanned. So everybody gets a CAT scan anyways. So, supportive, IV fluids, analgesia is important. Bet you didn't think I'd say that. But pain management is important. NG2 for severe pancreatitis. Antibiotics aren't always indicated, but we you know, sometimes we give it. There are reasons, times to give antibiotics and times not to. And it's usually unless you can prove a necrotizing or an infected pancreatitis. CVP, Foley, or Swan. Inotropic support. Once their fluid status is balanced. I mean, I think that's some of the times the problem, particularly the medical patients, we're giving these inotropes before you adequately replace their volume, and you get into trouble. The severe pancreatitis, supportive surgery, only if you can prove that phlegmon or that ischemic or necrotizing pancreatic bed is infected. And that's where fine needle aspirations come into play. Again, depends on how aggressive your radiologists are. But many of these pancreatics, get fine needle aspirations at this stage in their radiology department. If it's gallstone and you proved it by MRCP, you get a sphincterotomy if they're worsening or they're getting ascending cholangitis. Different causes of pancreatitis. For the United States, 90% is stones or alcohol. And then we've seen the drug-induced. I think we've seen some infectious causes. Hyperlipidemia that is not uncommon. You have to get a lipid panel and cholesterol. Anatomic abnormalities, I've seen that where you get a sphincter lodi and congenital abnormality, and she kept coming in every 3 months with pancreatitis. So we figured it out. More causes, infections. Don't see mumps too often, but it does cause it. And duodenal ulcers sometimes can penetrate posteriorly into the pancreas. I've seen that. And ERCP, that's why you don't always rush the ERCP. I mean, the ERCP, I remember one GI did a ERCP, gave him pancreatitis. He walked out of the hospital 4 months later. I mean, it can cause a bad pancreatitis. Ranson's criteria, my favorite, but actually I think I have 2 slides on it. Let's see, this one might be a little easier. From the time the patient comes in to the 48 hours, the hematocrit falls 10 points, the BUN rises 5, calcium falls below 8, they're hypoxic, their base deficit or acidosis is greater than 4, and they're taking on fluids. And then, again, it depends on how many of these have. Greater than 3, you can pretty much settle on this patient is going to have some pretty bad pancreatitis and high morbidity and high mortality. Greater than 3 criteria, get a CAT scan. If it's standard pancreatitis, you go to ICU, supportive care. TPN always becomes important. They like you to use the gut. I don't know that always works because the gut, you get a profound ileus with pancreatitis. Clinical improvement, supportive care. No improvement, fine needle aspiration. If it's sterile, supportive care. If it's infected, you operate. Deteriorating, you operate. So that takes probably one of the most complicated disease processes and makes it really simple. All right. And then I'll end on the sepsis bundles or protocol, which you probably know more about it than I do. I think You had to learn, it was part of being employed here, you had to learn this. But, you know, I find these bundles and all this interesting in this evidence-based medicine. You know, it's you know, they're taking evidence-based, they take all these observations and reports and then sometimes intuition and experience, and they put it all together and they come in with a level of 1 to 5 of evidence-based medicine. And you know, I think some of it's good. I think some of it might be a little bit of witchcraft, but you know, it's the way it is nowadays. So these are from the Society of Critical Care Medicine, and their goal was to decrease the mortality of sepsis by 25%. And what a wonderful goal, because too many people are dying from sepsis. And it comes in bundles. So a bundle is a group of interventions for a disease process that when taken together will have a better income than if you took each one of them individually. And then evidence-based medicine. Sepsis, these are the bundles that they want finished within the first 6 hours. Severe sepsis, a lactic acid greater than 4. First bundle, you measure the lactic acid. Bundle 2, blood cultures before you start the antibiotics. Number 3, antibiotics within 3 hours, which I think our emergency department's doing a very good job at, and within 1 hour if it's a non-emergency admission. Bundle 4, particularly if they're worsening hypotension, lactic greater than 4, fluid challenges, and you know, all this is kind of done concurrently. You don't do 1 and wait 2, but you give your usual bolus of 20 cc's per kilo crystalloid. And then at some point we're going to talk about basal pressures. And your goal, you always have to have a goal when you do something. For this, it would have a mean arterial pressure greater than 65. Bundle 5, you're getting a little more invasive. CVP greater than 8. Central venous oxygen saturation greater than 70%, or mixed venous oxygen saturation greater than 65%. Within 24 hours, Bundle 1, low dose steroids. I'm not even going to get into that debate whether they make a difference or not. I came through the era where we thought they didn't really make a difference, but Zygris, recombinant human activated protein C protocol, which we probably need a protocol here. Probably should need to be addressed, Tara. So, and glucose, greater than 70, less than 150. And then if on a ventilator, inspiratory plateau pressure of 30 centimeters of water. Symptoms, sepsis, hypotension, elevated lactate, and ineffective, basically it's ineffective arterial circulation. Vasodilatation, decreased cardiac output from all those bad myocardiac depressant factors. And basically you get a global tissue ischemia, and that's when I was talking earlier about PEEP. You know, if you measure the oxygen level at the cellular level, they may still be ischemic. Your boluses, 20 cc's per kilo. You have to have endpoints for your challenges, and again, mean arterial pressure, I said earlier, 65, depending on who you read, 65 to 70. You drop the heart rate below 110, obviously within limits. You don't want to put the patient in pulmonary edema. You can repeat the bolus, maintenance fluids, crystalloid versus colloid. Again, the SAFE trial, we talked about saline versus albumin. 7,000 patients, identical mortality. Albumin slightly beneficial for sepsis as opposed to the general population of patients or the surgical patient. Some of this is, we've already talked about. More invasive, CVP. Maximize central venous oxygen saturation, CVP greater than 8 unless they're on a vent. 12 to 15 if they're on PEEP. Most of your boluses are given before you place the line. Obviously it takes a little time to set that up. And this is a little controversial. I'm kind of a hematocrit of 30. You know, if they start dropping below 30 and they're sick, I give them blood. You know, I know a lot of people wait to below 8 or even 7, but I just don't think you can do that in an ICU patient who's very sick. You have to make sure they have oxygen carrying capacity. They have to have red cells to carry their oxygen. And it also helps correct your hypovolemia. Central venous oxygen greater than 70, we said that. and then you can start adding inotropes. Now, what I read said to start with dobutamine, not my first line of choice, but this is what they said, up to 20 mics per kilo. You can add norepinephrine to counteract the vasodilatory effects of dobutamine. Now, you understand these patients that you start, particularly dobutamine, because of its vasodilatory effect, they've got to be volume isovolemic. You can't give these to patients who don't have enough volume on board. They will get into trouble. They'll either drop their pressure or you'll vasoconstrict them more and you'll get in-organ damage. And I think that's where maybe some of our doctors get into trouble. They say, well, I'll just put them on norepinephrine, and they walk away and they come back 12 hours later. I mean, these patients have to be watching the fluid status particularly. If you need a CBP, you get it. If you need a swine, you put it in. You got Dr. Luby here. She can put them in. So vasopressor, contraindicated if patient is inadequately volume resuscitated. Vasopressors may worsen inadequate organ perfusion, kidney, and gut. Increased left ventricular work, decreased cardiac output, unless you have them isovolemic. You put in an A-line, norepinephrine. This literature said norepinephrine dopamine, which I kind of like that combination. Epi and phenylephrine are not your first-line drugs because of the effect on the splanchnic circulation, and then I think we use vasopressin. Dopamine, you know all this, increases blood pressure by increased cardiac index, increased stroke volume, increased heart rate, minimal effect on the systemic vascular resistance. Low doses, I still believe, increase your splanchnic circulation. There's all kinds of controversy on, well, does it affect renal perfusion? And some of the later literature says it doesn't, but I just know after 30 years, if I give it, the patient starts urinating a little bit better. It can alter your inflammatory response. Norepinephrine, when I went through training, it was called Levophed, leave them dead. We were taught not to use it. But more recent studies says that it's probably not a bad drug. Alpha and beta agonistic effects, mostly alpha. Adrenergic agonist, vasoconstrictor, and obviously increases your SVR and your mean arterial pressure. And it doesn't really affect the end organ as much as we thought it did, particularly if the patient has adequate volume resuscitation. So, and basically what they're saying there, you get a patient with by number CVP or SWAN, they have adequate volume, but they're still hypotensive, then you throw in your inotrope. You don't just keep throwing in volume, And you will get an adverse effect on the kidney if the patient is hypovolemic and or hypotensive. And increase the can increase the mean arterial pressure and the GFR in septic shock. So again, sometimes a little different effect with septic shock as long as the volume replenished. And I think I'm going to end there. I kind of covered a potpourri of fluids, electrolytes, crystalloid, colloid, surgery, pancreatitis, and sepsis and bubbles. Any questions? Yes.
Regarding the pancreatitis, for the causes of it, are you always, or what percentage of cases are you able to find the definitive cause?
Well, I think, like I said, in America, 90% is either stones or alcohol.
That you're able to?
Yeah, either by history or by seeing it on exam.
And does that include the pseudocysts, the patients that come with the pseudocysts?
Well, the pseudocysts are usually the result, in my experience, of a bad pancreatitis.
Over
And it'll take up to 6 to 8 weeks to develop. They'll get better, and they'll have a little phlegmon or collection and a little cyst while they were in the hospital, and sometimes it gets bigger, and sometimes it never goes away. And you watch them for 6 to 8 weeks. And most of the time, they'll get reabsorbed and go away, as long as you're not infected or expanding. I guess they can cause pancreatitis if they're pressing on the duct or the egress of the pancreatic secretions. So it's probably one of the minor causes, but usually it's the result of a bad pancreatic process. And like I said, most of the time they get better on their own. A lot of times sometimes you have to drain them, which in the old days we'd have to go in and sew the stomach to the cyst or loop a bowel to the cyst and just let them drain that way. Nowadays they do that pretty much endoscopically. They'll put a scope down, stick a needle into it, and then drain it.
When you talked about pain management for the pancreatic patient, would it be recommended to put them on PCA pumps at
Yeah.
various times?
Yeah, as long as they're capable of giving it to themselves. A lot of them have mental status changes. I mean, that's probably what, and again, you get into a debate that, sometimes I have to get pharmacology involved. Morphine sometimes, because of its effect on the sphincter vodi, can actually make the pancreatitis worse because it spasms the sphincter vodi. Demerol, we can't give IV anymore, so do you go, and you know me, I don't use a lot of pain medicine, but you probably have to do PCA, and either the nurse monitors it or the patient.
We have a lot on third floor that'll end up getting like 2 milligrams of Dilaudid every 2 hours.
Yeah. But they can make that into a
Seriously,
PCA.
Every 2 hours they're calling.
Well, I don't know, I guess, if they're alert enough to be able to request it, I might question, the degree of pain that they're really having. You know what I mean?
But if they know that they have it, it's,
No.
you can't, it's kind of hard to.
To keep giving it. Or
Well,
ask
you're
the
right,
doctor
but-
to wean it a little bit, and you drop it down, you drop it in half, make the duration a little longer, and eventually you wean them off. And again, they have to go by how the patient, when all else fails, you examine the patient. I mean, we're so busy looking at numbers and monitors, and, if we just walk in and look at the patient, spend 10, 20 minutes. And if he's in there watching the football game, he might have an issue there. And the third floor, the medical floor is a little different than the ICU. And, again, I agree with you. I'd be a little cautious on that one.
Now, NG2 for pancreatitis. Why do they want to feed them? I mean, I don't understand, because we were always told don't give them anything by mouth, and
Well,
that's how you let it cool off. Is there
I think there's a little bit of difference between how GI doctors and medical doctors handle pancreatitis and an old surgeon like me. I mean, I always thought to put in NG2, particularly the severe pancreatitic. I'm telling you right now, that gut is not working. I don't care how much you want it to work, how much of the tube you want to put down there. That tube finger is just going to go down there and sit, and he's going to vomit it up. Okay? I mean, they have a profound ileus. I mean, you can see it on X-ray. Even, medical school 101. What is the X-ray diagnosis of pancreatitis? An air fluid level in the mid-abdomen, because that loop of bowel sitting over the pancreas is not working. And so for your severe pancreatitic, I still put NG's tubes down. Some of the literature says you don't have to. And believe me, we don't put down many tubes anymore like we used to. I mean, it used to be in surgery you didn't get one as they walked in the door. But, I remember Detroit Receiving, we had a guy who drank all the time. We just handed him the tube, he put it down himself. Just depends on how bad the patient is. Obviously, to feed a patient nutritionally, you want to use the gut. Any disease process, anything with the patient, it's better to use the gut than IV, but sometimes you can't. And you have to look at the patient. You can't just say, okay, start 10 cc's per hour. And you really think you're making a difference with 10 cc's per hour with the tube feeding? I don't think you're making that much difference. So.
Thank you.
Thank you.